Oh, I gave a very childish talk. I was talking about a story that I wrote about just about 2 months ago, where the BBC ran a story saying that there was a threefold variation in the number of people dying from bowel cancer in different parts of the country, and they were claiming that this was due to a real variation in, there was a real reason why people were dying of bowel cancer more in one place than in another, and I was demonstrating how you can show beyond question, really, with straightforward, easily understandable statistics, that a threefold variation is exactly what you would have expected, just simply from the play of chance. And then more than that, and kind of more mischievously than that, I showed that after I'd explained that, because I don't expect every journalist in the world to know about sampling error and funnel plots, but I do hope that once you've explained that they would go, oh yeah, maybe we did mess that up. But instead they wrote a letter denying that black was black and white was white, and that annoyed me a little bit. I don't know. I don't really follow sort of big science stuff. I mean, there were lots of papers that I thought were pretty interesting. There's a really good one in Science this week about an amazing new algorithm for spotting patterns in data that is kind of doesn't care what kind of fit you're trying to get for your data. It'll fit it to a curve or a J-shaped curve or a line or in anything. And that, I think, is going to be really interesting, but I've only just read it today. But I suspect it will be quietly one of the most transgressive papers to be published in quite a long time. It's probably not political or budgetary restrictions that stop you doing interesting work. I think it's mostly ethics committees. I mean, the study that I would do, I say ethics committees, I mean, I think they present unethical regulatory barriers to life-saving research in many cases. The thing that I would do is, every single time that there was any uncertainty about which of two currently available, widely used, safe treatments in the NHS was going to be the best for a particular patient, I would just randomise them, and I would follow up how they did, whether they lived or died, from routinely collected electronic health records. So we don't know still what the best treatment for stroke is when you're in A&E, and we could recruit enough patients to find that out in the next 24 hours of stroke patients in the UK. And for death or outcome at 6 weeks, we would have our answer in 6 weeks. You know, that's how tangible and doable this kind of stuff is. And it's the barriers which are put up partly by computer systems not being very well set up for just reaping electronic health record data for that, but also mainly ethics committees saying you're not allowed to randomise, even when there's even when it's already an essentially arbitrary choice between two treatments because you don't know which one's better. So I would say no treatment uncertainty without randomisation. 40 million people have taken Prozac since it came on the market, and only 4,000 of those have taken it in the context of a randomised trial comparing Prozac against another antidepressant. And that's nuts, because we still don't really know which is the best, if any, of them. 40 million people have taken it, but we only did research in 4,000 of those episodes. That's nuts. If you're just arbitrarily going to get maybe Prozac, maybe citalopram, maybe sertraline, then you should just randomise every time if you don't know which is best. I'd give them all. I mean, the great thing about science is it should be freely accessible and openly accessible, and all scientific papers should be available to everybody who wants to read them. So I would give everything. And actually, that is the really seriously amazing thing about the way the world has changed in the last 10 years. Not a day goes past when I don't sit at my laptop just in awe at the phenomenal stream of data that I'm pumping into my brain.